Here we go. All right. Welcome and thank you everyone for joining today's webinar. This is going to be a Q&A webinar actually, which means I'm going to be answering a lot of questions, some that you pre-sent, some that we prepared, and also during the webinar or even now, you can write down each and any question that might come up in the Q&A section right here in the chat. My name is Dr. Sophia Wenzler. I'm a licensed clinical psychologist and also the clinical lead here at Stop OCD. Stop OCD is basically bringing this webinar to you, sponsoring it. It's a therapy program that tries to make evidence-based and effective therapy for OCD accessible and financially, but also geographically. And it consists out of two main elements, I would say. One is an evidence-based, tailor-made program that you go through on your own, online, via sessions. And the other element would be our expert therapists that guide you through this process step by step. You communicate with them daily via written communication, and they will answer every question you have, help you with the exercises, and really also dive deep with you in terms of understanding everything you need about your OCD. Yeah, so let's just dive right in. The first question: what exactly is OCD and how can someone tell the difference between OCD and everyday worries or habits? Wait, let me just check before we start. There's one question already in the Q&A. Okay, great. It's a real question. Sometimes people write to me that my mic is not working or something like that. So I always like to check first. So I'm going to get to that question for sure later on. Okay, what is OCD and why is it different from everyday worries or habits? That is a great question because OCD is becoming more and more part of everyday language. Many people are aware of OCD, but not so many know what it actually means to have this clinical diagnosis. And you basically have the answer in the name itself: obsessive-compulsive disorder, OCD. So the obsessive stands for the obsessions or intrusive thoughts. I like to call it intrusive thoughts more because I think the intrusive is really a huge part of it. And intrusive thoughts are different from worries because when you worry, you're like concerned about a real event that happened in the past or that will happen in the future, where you're trying to solve a problem. And sometimes worrying can turn into rumination when you kind of circle around this thing and you can't really find a solution for it. But intrusive thoughts are different. They kind of come into your mind unwanted. It's not that you actively think about it, they just come up and then the thought itself makes you really scared, causes a great level of distress. And you don't want these thoughts because the content is usually not in alignment with the person you think you are or the values you hold. And they almost feel like they're not your own thoughts. We call that ego dystone. I had a 12-year-old patient who said, "It's my brain sending me those thoughts." And she didn't really know what she was saying. And she also didn't think about the fact that all of her thoughts come from her brain. But what she meant was there's almost something inside me that sends me the thoughts, and I feel like they're not really my thoughts. So that's how those are different from worries, I would think. And then the C stands for compulsions or rituals, which are the things that we do to then deal with the distress that the thoughts cause. And those are different from habits. First of all, because of the purpose, because you want to relieve some kind of anxiety, and also because usually you feel compelled to do them, and sometimes you even have to do them over and over again, just like the classical washing your hands. And compulsions or rituals can be a lot of things. Let's say, for example, a person has an intrusive thought. He's standing on a balcony and has an intrusive thought of jumping off the balcony of the 5th floor. He's then this is like a weird thought to him. Like, why would I do that? I'm not suicidal. It's so weird. Where's this thought coming from? And he might feel a lot of distress if he takes that thought seriously, right? And then there's different rituals he might engage in. There's behavioral rituals. He might really grab the railing of the balcony so he can't jump off, or even maybe put his hands in his pockets. So he can't grab it and then try to like lift himself up. There's mental compulsions where if you have, for example, that mental image of yourself jumping off the railing, um, you might want to try to neutralize it with a different picture. Or I had this one client, she kind of had those intrusive mental images, and then she imagined like a huge red cross in front of the picture, the internal picture, almost just to make sure how much she didn't really mean that. Then you have avoidance. You might not go on balconies anymore, and reassurance seeking, which involves other people, where you ask them, "Why I'm not like why I would never jump off the balcony, right? There's no way I'm suicidal without knowing," or stuff like that. Um, so that's very different from a habit. And then finally, the D stands for disorder, because worries and habits are a part of life, right? But OCD is a disorder that not everyone has. It's a clinical diagnosis, and it means it's not part of yourself, right? You're not so OCD. It's something that breaks out at some point in your life, and that you then have. It's not I am OCD, I have OCD. Um, and also it means that it severely impacts your functioning. A rule of thumb for the clinical diagnosis would be that it takes up at least 1 hour of your day, which is quite a lot of time. Okay, another question. Most of us can relate to OCD by compulsions, like washing hands, putting things in a certain way, or having things just right. What other ways can OCD show up? Yeah, so because the compulsions, the hand washing or the repeated saying things repeatedly, checking the stove, that's something you see. So you might even, witness it in someone that has OCD, although it's not always that obvious. But actually, OCD is a whole cycle, and it's very, very important. Also, in Stop OCD, for example, we really emphasize the whole cycle, because the more you know, the more elements you know in the cycle, the more options you have to intervene and break the cycle. So it starts with a trigger. A trigger can be many, many, many things. Sometimes you're not even aware what's triggering you. And then you have the intrusive thought, which I talked about before. That intrusive thought, um, the next step is the interpretation. Um, you interpret this intrusive thought in terms of yourself, or in terms of the likelihood of something happening in real life. In the example with the balcony, um, the person in the example thought that having the intrusive thought made it more likely that they would actually jump off the balcony, although logically they would say, like, why would I? But it still scared them. It still made them think maybe there's something in that thought. Sometimes the thoughts make us feel like we're a bad person. But definitely it's very important people with OCD take the thoughts seriously to a certain degree. And that's why it then causes a lot of distress. So intrusive thought, interpretation, distress. And then we engage in the ritual, or avoidance behavior. And the cycle can basically be interrupted at any point, um, or any aspect of it. But the most effective way, for sure, as probably many of you know, is to reduce and eliminate the rituals or compulsions. That's the most effective way. Um, okay. I've been suffering from OCD for the past 4 years, and each day it gets worse. I wanted to know what's the best way to start if you want to overcome OCD. I've tried medication, but it doesn't work. I've tried to ignore it, but it gets worse to a point I feel sick if I don't do it. Um, that's a wonderful question, and I'm so sorry that OCD, if you're here, whoever submitted the question, has such an impact on your life and makes you feel so bad, you're not alone with that for sure. Um, there's many things in that question that you're saying. So first of all, yes, OCD gets worse when you don't treat it effectively. It almost breaks out. It can even jump from one theme to the other, or be in one theme and then also be in another one, and it can really take over your life. Then you mention medication and it not helping, which I cannot rule out that medication doesn't help. However, medication for OCD is complex, and there's a lot of psychiatrists that maybe know how to treat depression or anxiety, but that will not know how to effectively treat OCD. So when I have a patient who says medication didn't work, I always go into the details. Did you go to a specialist? Did you try more than one medication? What dosage did you try? Because usually the dosage, what you give for OCD is usually SSRIs or some kind of medication against depression, but you give it in a much higher dosage. And it also takes much longer until it works. Sometimes you have to work 12 weeks until you see an effect. So yes, sometimes it doesn't work. And definitely the most effective way is exposure with response prevention. But the fact that you try a medication once doesn't mean that it's never going to work for you. And then you ask me, what is the best way to start if I want to overcome? So definitely what I would recommend to do for you would be to do exposure with response prevention. Either with a therapist in your area, or you can start Stop OCD. But that is the most effective way. But you can't, I find the term overcoming OCD difficult because it basically is something that you have to manage. It barely ever fully goes away. You can be symptom free for a while or for a really long time, but you have to manage it. You always have to look out, not look out, but you have to be aware when symptoms are coming back, and then immediately do ERP again and relate to it, right? Because otherwise you're in danger of relapse. Yeah, I hope that answered the question. Another one. A lot of people think OCD is just about being clean or organized, but what are some of the other ways it can show up? Um, yeah, so that's again this way of OCD being part of the common language, always also almost like a slang, like I'm so OCD. What you're doing is so OCD, but usually it really is mislabeling something that's not really a clinical diagnosis. Also, a lot of OCD doesn't have anything to do with being clean or organized. That's usually just right and contamination OCD. Basically, OCD can sit on anything. It can go into any aspect of your life, which obviously is not a good thing, because once it is in this area of your life, it can be really debilitating. But I would say the core features that all different subtypes of OCD have in common are that there's a high intolerance for uncertainty. Uncertainty is never a good thing. We all realized that or felt that during COVID, not knowing what's going to happen is extremely hard to cope with. But for people with OCD, it's even harder. They seek the 100%, they want to be sure of things, and that's not how it goes in life, right? And then in terms of what does the OCD sit on, it can be anything that is important to me. Anything that if I feel like I might do it wrong or it is in danger, will cause a lot of distress, which feeds into the OCD. And there are some types of OCD that are more talked about. I just recently did this like little investigation where I looked into people who are famous and have OCD and openly talk about it. And fortunately, there's a lot of them, which is really nice. But the kinds of OCD, if they describe their symptoms, what they describe is usually responsibility for harm obsessions, for example, having to check that the stove is turned off or that the door is locked, or another kind of responsibility for harm would be to drive in your car and then wondering whether you accidentally ran someone over without noticing. And another kind that's talked about a lot would be contamination OCD. That's, I think, the one that most people know, with like washing your hands, not wanting to touch a door handle, having to disinfect everything because you're scared that there's germs that will harm you in any shape or form. But there are so many more things, so many. I feel like every day there's a new kind of subgroup of OCD, and some of them are much harder to talk about. You have, for example, aggressive OCD, where you have intrusive thoughts about hurting someone else, stabbing someone else, killing someone else, or yourself. Sexual OCD, where you have intrusive thoughts that have some kind of sexual context that is inappropriate to you. Religious OCD, for people who are religious and they having blasphemous thoughts, stuff like that. Hoarding OCD, ROCD. ROCD is definitely increasing. It's being uncertain about your partner or your relationship and obsessing about that. Those are some common subgroups, and some of them are really hard to open up about. But just so you know, in my clinical experience, the fact that we know more about contamination or responsibility for harm OCD doesn't mean that they're more common, not at all. Um, Aggressive OCD, for example, is really common. I see it all the time. So if that's what you're having, then you're definitely not alone with it. Yeah, so it can sit on anything. Interestingly, when I prepared for this question, I also thought about, even right now I have two clients who have the same symptom, but it's two different subtypes for OCD, right? So it can come in all shapes and sizes. So those two patients both have OCD that revolve around writing. One is a researcher who writes research papers, and one is a writer who writes novels. And both of them kind of are obsessive about doing it right, getting it right. They write different versions, they get lost in the details, they go over and over and over and over certain aspects of what they're doing, about the calculations or the right phrasing. And the effect is that they take a really long time to finish anything, and they're not being effective at all. And on the way, they experience a lot of distress, uncertainty, and feeling really bad about themselves and feeling like they're a failure. But for my researcher, it's responsibility for harm OCD, because she is really afraid that she will publish some data that is not completely 100% correct, which any one of you who's ever been in research knows that is a really high goal to achieve. And then causing harm by, or being a bad person because she published something that's not 100% correct, or where there is a mistake that she overlooked. Whereas for my writer who's writing novels, for her it's just right OCD. It's like, if the sentence doesn't sound perfect, then it will cause her to feel really, really bad, like a really bad feeling that sometimes she can't even connect to an intrusive thought. And also some kind of contamination OCD, where it feels like, for her, if there's one sentence that doesn't flow right, then it makes the whole book bad. It just kind of contaminates the whole book. So I think those are really interesting examples of how, OCD can be much more than just being tidy or afraid of germs or stuff like that. Okay, that's a long one. I have had OCD for almost 30 years. I've managed to have relatively long periods where it doesn't affect my life, but also many relapses. I'm currently going through an episode now and have been since early January. I seem to make good progress for a couple of weeks, but then almost back to where I started. Please, can I ask why or how you can feel like you've beaten and overcome it? And then it comes back. I don't know where I'm going wrong. My theme just now is really event subtype, which I know is irrelevant. I've had others. And then another question, may I also, like from the same person, may I also ask if premenopause and menopause can make OCD worse or more difficult to treat? Many thanks indeed. I'm looking forward to the call. Um, okay. So this person has been struggling with OCD for 30 years with ups and downs, which is not uncommon. As I said before, OCD doesn't really go away. You don't overcome it. It's not like the flu, you take medication and then you get rid of it. It's more like maybe not the perfect metaphor, but the one that comes to mind right now. Allergies that can flare up. And it's always like in the back of your mind and sometimes or in your body, right? But sometimes there's, certain grasses or seeds triggers that can bring it up. And then the better you know how to cope with it, the less it will affect your life. If you immediately know what medication to take, obviously for OCD, it wouldn't be only medication, then you can let it impact your life less and less. But the idea of just treating it and then never having to deal with it again is unrealistic for most people. Also, even when you're making progress and you're doing therapy, then sometimes there's just downs. It's not a linear progress therapy. It's a lot of ups and downs, and sometimes the downs feel like you're just back to zero. But that doesn't mean that there's no hope, and that doesn't mean that it cannot get better. Obviously, like one thing that would really interest me is what you're doing to treat your OCD, whether it's ERP, whether you've tried ERP plus medication, how long you've tried it, and how consistently. Um, and I think those are all things that affect how you're feeling and the fact that it comes back. So it's I'm always saying like it's like the OCD keeps on raising its head and you have to relate to it every time. So yeah, it's not difficult. It's not easy. It's a difficult condition to deal with. And in terms of your question concerning menopause or perimenopause, both perimenopause and menopause, yes, that can definitely influence OCD. It's really hard sometimes to make clear statements about how, you know, generally how brain chemistry works with OCD, and then specifically how other things affect this brain chemistry. But we know for sure, right? There's imbalances for example, serotonin in your brain, and the drastic changes in hormones during menopause or perimenopause can definitely affect the whole system. Hormones and neurotransmitters um, in the body. So that in and of itself can already worsen OCD symptoms or even lead to an outbreak. But also perimenopause and menopause comes with other problems such as changes in mood, sleep, and anxiety. And those then indirectly also affect OCD in return. It's basically every stressful life event, also giving birth, starting a relationship can trigger your OCD. That's why I'm saying it's you have to stay on it almost all the time. Mm, okay. Ooh, okay. How can someone tell the difference between a random intrusive thought and an OCD thought? That is a good question. There is actually no difference at all. What a lot of people don't know is that we all have intrusive thoughts. There's a research paper, I forgot what exactly the number was, but I think it was around that 80% of people have experienced intrusive thoughts, and like a really long list. It can be basically anything that causes you distress. My secret hypothesis is that everyone has intrusive thoughts. I for sure have intrusive thoughts. Um, the difference would be that when you have OCD, those um, thoughts become unbearable because you interpret them in a certain way. So my intrusive thoughts, for example, are aggressive thoughts. When I have a sharp knife in my hand, I get this intrusive picture of me stabbing whoever is close to me with that knife. But because I know that doesn't make me a violent person and I would never do it and have never done it, I know it's OCD, right? It's an intrusive thought. I just, you know, I don't react to it. I put it away. But I know for people with OCD, it's not easier said than done, right? It causes a lot of distress. The thoughts might come much more frequently, might be much more alarming. And this is how, for people with OCD, like some of my clients say, it's like they have a sticky mind. It's just the thought sticks and then it comes again and again, and it just drives you insane. But it's the same thought, basically. Um, okay, next question. I have intrusive thoughts. Does it make me a bad person? Yeah, I think that really relates to the previous question. So everyone has intrusive thoughts, and they have nothing to do with you usually. Actually, they do have something to do with you. They usually tell you about something that is, how do you say that, near and dear to you. If you didn't care about the content of the intrusive thoughts, you wouldn't pay too much attention to it. But because you care and because it's about something that you um, value or that is important to you, the thoughts come back. So if at all it says something about you, it doesn't say that you're a bad person. It says that something is really of value to you. For example, if you are religious and you have religious OCD of blasphemous thoughts, then it just means how important it is to you to be, a good believer in whatever faith you are religious in. Um, and the shame or the mere thought that this is making you a bad person is what makes the thought so sticky. Shame is a sticky feeling. Shame, yeah, shame and embarrassment. Um, okay, another question that was pre-submitted. Can needing to point out issues with the house be an OCD urge? Or I would not call it an urge in that context. I would call it a compulsion, like pointing out issues with the shower when it's loose and not broken. Um, Okay, that's an interesting question. Just from the question itself, I cannot tell you if it is OCD. I can definitely tell you it could be OCD. And when I say OCD, also it could be an intrusive thought or a ritual. To really meet the criteria for OCD as a disorder, we would also have to check how debilitating it is, how much it impacts your functioning. But it really, like in my private practice or in real life, it doesn't always matter if it really meets the criteria. As long as it's an intrusive thought that's met with a ritual, you treat it the same way. Anyway, so if behind you feeling the urge or feeling compelled to point out issues with the house, if behind that there is some kind of fear, for example, if I don't point it out, it will break eventually and someone's going to get hurt and then it's my fault, that would be OCD. Or if it's just right OCD, then it would be like, okay, I have to point it out. And as long as I don't point it out, I'm going to be tense and I'm going to have this feeling like something's not right. So I just have to do it. And I might even have to do it again, or I might have to double check if the other person heard me or reassure myself that they actually took it to mind. Yeah, so it could be. Really depends. Okay. We have heard that ERP is the gold standard. What does this mean, and why is ERP considered to be so good for OCD treatments? Um, yeah, what does it mean when something is the gold standard? So, with every, or not with every one, but with a lot of psychological conditions, we have kind of one therapeutic approach that we say is the most effective. And it's not that like psychologists or psychiatrists say it's so, it means that there's a lot of a big body of research that proves that it's effective. And that is the case for ERP for sure. There's tons of research about the effectiveness of ERP for different kinds of OCD, for different ages, for different geographical areas. It doesn't work for everyone. Obviously, there is never a 100%, but if you compare it to other therapeutical approach, then ERP is very, very effective. And I always advise to, when you have OCD, even if you consider OCD or medication, start at ERP or medication, start with the ERP, and then if it doesn't work, add the medication. But ERP, gives you the skills to cope with OCD, and since you will have to cope with it possibly for different periods in your life going forward, it's really important to have those skills, because you don't want to get into the cycle of taking medication every time again. Like, some people do have to take medication for a long time, but first try to do it using ERP. And it is so effective because it challenges the core of OCD, right? So what is ERP? ERP means exposure with response prevention. It means that you let yourself be triggered, you let yourself have an intrusive thought, and then don't do the ritual. Which sounds very simple for someone who suffers from OCD. That sounds like impossible. It's so hard. And I feel so much for my patients when I go through ERP with them, because I know how hard it is for them. But it tackles OCD at the core. OCD makes you believe that the intrusive thoughts have meaning and value. It makes you believe that there is some truth in there, and you have to do the ritual just in case it's true, right? You do have some part of you knows that it's exaggerated and not true, but the other part that says what if, right? What if is so strong that you engage in the ritual, and as long as you engage in the ritual, you can never find out. There is a little metaphor that I usually tell my patients when we talk about this. It's like, imagine, how do you call this? A hiker or explorer hiking to some like really far off village in an East European countryside. And then they see the village, and they see that inside all the houses and around all the door frames, there's a lot of garlic. And then they ask, why do you guys really like to eat garlic? And the people say, no, no, that's to keep away the vampires. And then you might say, well, there's no vampires. Like, you don't need the garlic, Nick. And they will answer, of course, there's no vampires because we have the garlic. And so for those villagers in this metaphor or story, obviously they would have to take the garlic away to check if there's really no vampires, if vampires are really not real. But, for the off chance that there's really vampires, taking away the garlic is really scary. I mean, if there's even really, really low chance, and then the vampire will kill me, it's over, right? So I'd rather not take the chance. It's just the garlic. And obviously, having a lot of garlic around you is not as debilitating and time consuming as doing a lot of rituals. But that's the basic idea of ERP. What ERP does, it shows you that the rituals really have no effect and that you don't need them. And it shows you that you can deal with the distress. So just like, I think one of the pre-submitted questions, they said, like, I cannot, like, I have to do the ritual, otherwise I will feel physically sick. And that might very well be true. In ERP, when you don't do the ritual, you experience intense amounts of anxiety, really bad feelings. It's really hard. It might last for a while, but anxiety is not dangerous. Feeling sick from anxiety is not dangerous. Anxiety will not let you faint or die. It's not going to hurt you. It's just going to be insanely uncomfortable, and every inch of you is going to want to do the thing that's going to take the anxiety away, but you are strong enough to stand it. And in ERP, also, the good thing is that we do it gradually, right? So we're not going to start with the most difficult part. Okay, I think that's enough in terms of pre-submitted questions for today. I would really like to invest the rest of the time to get to the questions that you posed right here. So Let's do that. I have an OCD urge to point out mirror issues with stuff like the shower at my house, even when there's nothing majorly wrong, but I'm delaying it and texting my parents the urge when I'm out of the environment. Wait. I have an OCD urge to point out. Is that the same person that asked the pre-submitted question with the house issues? I have an OCD urge to point out minor issues with stuff like the shower at my house, even when there's nothing majorly wrong, but I am delaying it. I think my parents urge when I'm out of the environment. So delaying it is usually like if your final goal is to not point it out, because actually when you think about it reasonably, pointing out is really not effective or necessary and you don't want to do it. Like that would be the premise, right? If you're posting this, you probably there's some part of you who thinks this is exaggerated and you should do it less. And then that is basically one way to start working on it, delaying the compulsion. For example, if you feel like touching the doorknob and not washing your hand is too hard at this point, that's also what I mean with gradually, then I will sometimes, practice with clients to just delay washing the hands for 5 to 10 minutes or longer, just so you can prove to yourself that this uncomfortable feeling of with contamination OCD, it can even be, like a tingling on the skin or like really a physically uncomfortable feeling, that you're strong enough to take it. And then we constantly make the frame of delaying it longer until you can actually emit the ritual. So that's a good idea. The texting my parents the urge when I'm out of the environment, that would be, I think, some kind of do you call this again? Confession or reassurance, depending on what you're writing to them. So it would also be considered a ritual that you want to reduce. Oh, excellent question. Can a place make OCD urges worse, like being home makes my urges worse due to family issues? Absolutely. Places can be triggers because they remind you of things. Places can be triggers because they cause you stress. Obviously, for a lot of people, being home is a place where you feel comfortable and protected, but um, at the same time, or even you can feel protected, it can still bring up issues. But for some people, they also just don't feel safe in their home, and all sorts of stress can lead to OCD symptoms. A lot of the time, if you have OCD or not, the only one. A lot of my clients, when they go back home, they see all of a sudden after therapy, they start to see all the signs of OCD in their family, and that in and of itself can be triggering. It can also be healing, because seeing it in another person can make you see how exaggerated or unreasonable it can be. But yeah, absolutely. Um, when intrusive thoughts of harm, OCD involving knives come up, I guess. What is the best way to work through that with ERP, as being asked to hold a knife brings distress? Excellent question. Um, so what you would want to do is um, kind of create a hierarchy of different exposures you can do. And they don't all have to be in reality. They also can be mental exposures. Um, and anything that you can imagine doing is possible. So what you're saying is holding a knife brings distress. Um, would holding a knife, I mean, if it's also involving harm to yourself, then probably holding a knife on your own would also be distressful. But if it's um, the fear of harming someone else, and maybe holding a knife without having anyone around, or starting with a knife that is not sharp, or a plastic knife, or you could kind of imagine or write a story of holding the knife and actually going for it, doing something horrible with it, and then almost like a horror story, almost like writing it to the end. That's called ERP, like imaginal ERP, where when you can't really can't really do real life ERP because your thoughts are too abstract, or you can't really realize them, then you imagine it. Or this is but this is also like really high up the hierarchy, so I'm going to take a step back. Maybe watching movies that trigger you, where you see people being violent with knives. Imagine anything that might possibly trigger you, and then think about what the distress level it would cause you. If holding a knife would be an 8 and you say from 1 to 10, right? An 8 is too high. Then think about what is a 4 for me. Would it be watching a picture of a knife, or looking at a picture of a knife, or watching a movie, or reading about um, violence with knives, domestic violence, whatever it is, whatever triggers you, and then stay in that moment without doing anything about it mentally or physically. But this is really hard to do on your own. Like, it's best to find a therapist who can guide you through that. Um, Another question: is feeling bad or dirty for randomly starting at someone's groin by an accident a form of OCD? Staring, you mean, is feeling bad or dirty for randomly staring at someone's groin by accident a form of OCD? And feeling need to confess to boyfriend, or if I say intrusive thought to friend, feeling need to say to boyfriend, for example, saying sexual tension between me and someone at work as a joke. That, like, again, I'm not going to diagnose OCD without knowing you and just based on those sentences, but it definitely sounds like OCD to me. That's very common. Um, uh, Actually, specifically looking at someone's groins or someone's décolleté, like someone's breasts or whatever, any part of the body that can be sexualized. It happens to us. We're all human. Sometimes we do it intentionally, sometimes we do it accidentally. But if that makes you feel dirty or bad, and then makes you feel like you have to do something, like confess it, then that becomes a cycle, and you will be more and more aware of accidentally looking at people, or you're going to try to, like, really, really hard not look at those areas, but then you're still aware of the areas. And that sounds like the start of OCD, and that would definitely be something I would want to discuss with a therapist. All right. Well, I've been talking for a long time. Last question, and then we're gonna be done for today. My mouth gets full of saliva frequently, so I swallow it frequently. There is no thought that comes into my mind that I am aware of that is related to the situation or pushes me to do it, but I have difficulty in stopping it, and it also is distressing for me. Does my situation fit into a diagnosis of OCD? That is such an interesting question. Actually, I've never heard of this symptom. What it kind of reminds me of, but is not the same, that I witness with a lot of people with OCD is specifically in the evening going to the bathroom many times before they go to bed. Like, their bladder is actually empty, but they kind of feel um, the tingling or whatever urge to do it, and they have to go several times to the bathroom, or even in the middle of the night. And really, I don't think it fits the diagnosis of OCD, but in terms of my experience, I've witnessed such things with people who have OCD. The question is, maybe you have other areas in your life where you engage in compulsive behaviors, or where you have intrusive thoughts, or you just write OCD, maybe. That alone would not justify the diagnosis. And also, there is really a somatic effect in there that we would see when we treat somatic disorders, where the more attention you pay to a certain body part, the more you will see a reaction in that body part. For example, people who have panic disorder, so that would be the pathological fear of having a panic attack, they will be much more aware of their heart rate going up. And even things like going up the stairs might be so triggering for them, they avoid it, because just feeling the heart rate and then paying attention to it becomes so intense and so scary to them. Or when you're dealing with pain, right? The pain can really be increased by how much you focused on it, and decreased by how much you manage to divert your thinking somewhere else. And it's really important here to distinguish between avoiding to, okay, well, this is there, I know it's there, but I'm going to go ahead with my life. I'm not ignoring it. I'm not pushing it away. It's there. And me and this thing are going to go through my life. And this is not going to stop me. Um, yeah, so definitely focusing on your mouth and focusing on like how you have saliva in your mouth is probably going to increase the amount of saliva there. So focusing on other parts in your body, you didn't even ask what, what I would do with it, but I just instinctually went there. Um, the question was whether it's OCD. I don't think it meets the criteria to of OCD, but it really reminds me of what some people with OCD tell me. And one maybe exercise that might be really helpful for you would be a body scan. It's a mindfulness exercise. We also have it here in our program, Stop OCD. We actually have a lot of tools with different exercises that we kind of custom fit to our clients' needs. And a body scan is something that teaches you to go through your body without getting stuck in one body part that feels uncomfortable or weird, and just move from body part to body part without getting attached. And that might be really helpful for you. All right. Thank you for all of you um, staying for so long and listening to me talking for such a long time. I really enjoyed those wonderful questions. I hope wherever you are, you're going to have a wonderful rest of your day, and also look forward to seeing you again for upcoming webinars. Thank you so much and have a great day.